next call upon Dr. Vidhya N to give her talk on pediatric lid and adnexal injuries. Dr. Vidhya is a senior consultant in Eye Foundation Coimbatore in oculoplasty.
Very good morning, and thank you, Lakshmi, for having me here. So I'm going to be talking about eyelid and canalicular tear management. We all know that ocular adnexal injury is the most common scenario that we get to face in our day-to-day practice, and it's important that we know the principles very well, because it's not just repairing this lid tear. It is to prevent all this lid notching, exposure keratopathy. We need to prevent ocular surface disruption, and we also need to address the aesthetic concerns of the patient, and we need to prevent the functional problems like canalicular stenosis and epiphora. The basic principles remains the same. We need to have a very clear-cut history, very careful examination, and we need to prioritize our treatment depending upon the presenting condition of the patient. So the detailed history should include the mode of injury. We need to be aware of the penetrating injuries can lead to all intraocular and intraorbital foreign bodies. Dog bite requires a different level of management, so we need to be aware of that. Physical confrontation has got medico-legal aspects, so we need to note down in our history. And injury with hooks, which is especially more common in our area, has got the propensity for causing canalicular tear, so that we need to remember. So I talked about the medico-legal aspects. I'll also cover it in the subsequent slides. And we need to be knowing about the time since last feed, because most of these cases we would operate under general anesthesia or IV sedation. So the ocular examination should include globe integrity. We need to be sure of that. And we need to record our vision and color vision wherever possible. And pupillary reaction, we need to be specifically looking for RAPD. Extraocular muscle and the motility problems we need to be aware of, because some of these penetrating trauma will also be including fractures, and radiology wherever indicated, specifically to rule out foreign bodies. And preferably all these cases should have preoperative photographs as well. So the management will differ with full thickness or partial thickness tear, or sometimes the marginal involvement will have a different line of management. Specifically, we need to be aware of this medial canthal injury, which is medial to the punctum. We need to rule out canalicular tear, either with direct observation or by doing a probing. One clinical tip would be a laterally displaced wound with distorted medial canthal area usually has got canalicular involvement. So the indications for imaging, we'll do that whenever we suspect an intraocular or intraorbital foreign body, or when we suspect a fracture, or when there is an optic nerve avulsion or suspected intracranial injury. The modalities we have ultrasound, CT or MRI. I would prefer CT because it's quick, it identifies the fractures, and it is also less financial implication for our patients. Documentation, as I mentioned earlier, clinical photograph is a must, and we need to have explicit documentation about vision in the eyes. Whenever we say about documented or guarded nil visual prognosis, definitely we need to document that. And we also should mention about the possible need for repeat surgery or intervention. Some of these cases might require some revision or exploration. And in case of head injury, the priority is attending to the patient's general condition first. If you have a coexistent globe rupture, it is globe rupture first, followed by lid tear repair. Anesthesia, majority of these cases in adult can be done under local anesthesia, in which case we would prefer an infraorbital and infratrochlear block. But in children or extensive injuries where we require longer time to repair, may preferably be done under general anesthesia or IV sedation. So I'm going to be sharing top 10 points that we need to keep in our mind whenever we deal with these kind of cases. Number one is a thorough wound inspection. We need to look for foreign bodies like this. So some of these foreign bodies may be embedded in the site of injury itself. So that has to be explored and taken out. And some of these tissues may appear a little necrotic, but we don't have to excise the excess tissue. We don't have to debride it, because apparently avascular or necrotic appearing tissues will usually heal well, because lid is a very vascular structure. Lid tear marginal repair has got a specific technique, which is far near pass technique. We go 3 millimeters from the cut edge of the wound 3 millimeters down, and we reverse our needle and come back 1 millimeter from either side of the wound, and then we suture the knot, and we need to be specific that this wound edge, when we finish our suturing, it should be everted, and we leave the suture knot a little longer, and we take it in our subsequent sutures. So that is the technique for lid tear marginal repair. And lid tear not involving the margin can be repaired as we do suturing in elsewhere in our body. So like a skin muscle flap can be sutured the same way we suture our lid tear not involving the lid margin. Canalicular injury, the critical factors here would be how extensive is the injury, whether it is proximal or distal. The coexisting lid abnormalities and ocular abnormalities will make it decide on our anesthesia part of it. And specifically for the canaliculars, one or both canalicular involvement we need to take up, and also the choice of stent that we are going to use it. So here's a short video on canalicular repair. The initial step is a punctal dilatation, and then we use a probe, a lacrimal probe, which will pass through this cut end of the canaliculus. So when we pass, we could identify the pale pink structure here. So that is the cut edge of the canaliculus. Usually if we use a higher magnification, that helps in identifying the cut edge of the canaliculus, or sometimes you can use adrenaline drops also to have vasoconstriction. So here I am using an Oro stent, which is a monocanalicular stent. This stent has got a small collar and stud here. So this will go and sit in the punctal area. So just pull it from the other edge. One tip here would be to use a non-toothed forceps and not to hold the tissues with the toothed forceps, because that tends to crush the tissue. So pull the monocanalicular stent, and usually in adults, because the punctum is little patulous, it goes out when we use a punctal dilator, but with the kids it doesn't happen usually, so you need to pull from the other side. So that makes it little tricky here, because if it is close to the punctum, then it is a problem. So for want of time, I'll skip this rest of the part. So usually we finish it with the peripunctal canalicular thing. A stent removal is very easy. Just do it in the OPD with the non-tooth forceps. You can pull out the entire stent in one go. So this is how we remove the stent. Usually we keep it for about 6 weeks. So periorbital fat, if it is there like this, it indicates that there is violation of the orbital septum. If it is in the upper eyelid, we should expect that there is an LPS involvement. So, and we need to repair it in the first go itself. And when we suture, we should take care not to suture the orbital septum. It may result in restrictive retraction like this. And sometimes patients do present with irregular apposition, which may require reconstruction. This particular patient, we have done a Z-plasty, and this is how he looks post-operative. Lid tears following dog bite requires a special mention, because this is more common in kids. We have to copiously irrigate the wound area. Rabies and tetanus prophylaxis to be observed, and infiltrate with the local immunoglobulins. 24 or to 48 hours we can do the primary repair. And systemic antibiotics are usually indicated, because this is a polymicrobial infection sometimes. So we need to remember the complications, many of it I've told, and meticulous repairs usually give excellent results like this. Thank you so much.
Thank you, Dr. Vidhya.